said, I'm sure you see a lot of patients on psychotropic medications when they come in for their procedures. So thought it would be good to, so we want to review common like psychotropic medication classes and their different uses, talk about potential interactions with anesthesia, and examine and differentiate our neuroleptic malignant syndrome and serotonin syndrome. I just thought it would be good to focus on those two since they're pretty rare and might be a good refresher for those, and they're pretty severe as well. So the first class we want to talk about is the most common that you're going to see, our SSRIs. So they can be used for a whole variety of things, so depression, anxiety, OCD, panic disorder, eating disorders, PTSD, and their mechanism is just to selectively inhibit your serotonin reuptake in the neuronal membrane. So you're going to get higher serotonin concentrations in the synapse, which is going to result in better neurotransmission, and down the line there's also some long-term effects on the brain receptors. So in effect, usually it's going to take about a month to see the clinical effects of your SSRIs, but really they're just going to increase your serotonergic neurotransmission. And so you have a multitude of examples. So you have fluoxetine, paroxetine, citalopram, escitalopram, fluoxamine. There's a few more, but these are typically the most common that you'll see. And usually the adverse effects are pretty mild with this class. That's why they're the most popular of the antidepressants. You can see some insomnia, nausea, stomach upset, diarrhea. Could see some sexual dysfunction. But the serious drug events, and what we're more concerned about, is potentially you can see some increased bleeding risk. Now there hasn't been shown to be any severe bleeding really, but it is something to think about if a patient's on additional anticoagulants or things that could potentially have an additive effect there. Also, they have an increased risk of arrhythmia, so they do prolong your QTC interval, and then that's another effect that you're really only ever going to be concerned about if a patient's on multiple QTC prolonging medications. And the one that we're going to talk about a little later is serotonin syndrome, which again is something that really you're going to see if a patient's on, for example, an SSRI and a different class of antidepressant together if one didn't work alone. And there's also some medications that they can interact with to potentially cause this syndrome. So we'll talk about that a little more in a bit. So notable drug interactions that you may be concerned with in an anesthesia setting is beta blockers. So some antidepressants inhibit the CYP2D6 enzyme, so you're going to get an increased plasma concentration of some of your beta blockers. So mostly you'll see this with metoprolol, propranolol, and carvedilol. And your biggest offenders in terms of SSRIs are going to be paroxetine, fluoxetine, and fluvoxamine. Sorry, those are your big inhibitors of this enzyme. So esmolol, for example, doesn't undergo this metabolism, so that's going to be okay. But if your patient is, for example, on a beta blocker and still taking one of these, you may see some increased hypotensive effect with that beta blocker. Now, your synthetic opioids, you might have an increased risk of serotonin syndrome because they are serotonergic. So meperidine, tramadol, and fentanyl, if a patient is still taking multiple antidepressants that have serotonergic effects, these opioids do carry a risk of potentially increasing the risk of that. And also your prodrug opioids are going to have a decreased effect. So hydrocodone, tramadol, codeine, because they undergo CYP2D6 metabolism and that's being inhibited, and they need that metabolism to be active, they're going to have less effect if a patient's taking antidepressants, like mainly paroxetine, fluoxetine, and fluvoxamine.
Can I have a question?
Yeah, of course.
So you're saying that if they're on the psychotropic drug with the synthetic opioids, you're going to have increased effect of those synthetic opioids, but if they're taking a prodrug opioid like tramadol, your narcotic effects is less.
So yes, so the potential for serotonin syndrome is greater, but the therapeutic effect is less. So yes, there's a little bit, exactly. But however, the recommendation is still to continue through the day of surgery because there's a potential for withdrawal syndrome with some of these, especially your shorter acting ones like paroxetine with a short half-life. So we don't really want to discontinue these. You just want to keep keep in mind these certain drug interactions, but normally you're not going to see too many issues with SSRIs as a class, and normally it's okay to continue. Now the next class is your SNRI, serotonin norepinephrine reuptake inhibitors. So these are also serotonergic medications, however they also work on the reuptake of norepinephrine. So they're going to increase your concentrations of both of these in your synaptic cleft and kind of increase the neurotransmission with both of these neurotransmitters, which are both thought to be involved in the pathogenesis of depression and some of these other psychiatric syndromes. So your examples are going to be venlafaxine, duloxetine, desvenlafaxine. These are three of the most common SNRIs that you'll see. So common adverse effects are pretty much very similar to your SSRIs. Serious adverse drug events that we worry about is, again, serotonin syndrome with these because they're also serotonergic, so they have the same concerns with those the opioids that I talked about. Now, the recommendation as well is to continue through day of surgery because pretty much every antidepressant class is going to have a concern of discontinuation syndrome, and really that the risk of that typically outweighs any possible interactions that you might see. So the next class is a class that is known for a lot of potential interactions. So this is your MAOIs, monoamine oxidase inhibitors. They're an older class of antidepressant. They have fallen out of favor because they do have a lot of greater potential for side effects and interactions. They're used for a lot of the same things, but nowadays they're really only used for treatment-resistant and atypical depression when the SSRIs and things that are a little safer don't work. So their mechanism of action is they're going to inhibit your monoamine oxidase enzyme, and that's going to prevent the breakdown of these catecholamines, so serotonin, norepinephrine, and dopamine, and so you're going to increase all these levels in the brain, and that works to, it has a therapeutic effect on depression and these other disorders. So some examples that you might see, and again, they're not too common, but their use has been increasing recently, is phenelzine, tranylcypromine, isocarboxazid. And so there's an important distinction between these is that these are your non-selective MAO inhibitors, and then the selective MAO inhibitors that you might see are rasagiline and selegiline. Now, and what I might add, some of these are also used for Parkinson's disease. So especially your rasagiline and selegiline, you'll see that. So common adverse effects are dry mouth, nausea, diarrhea. They have constipation. And then your serious adverse effects that you might see is hypertensive crisis. Now, this is one of the reasons that this class of medications has fallen out of favor, is they have this thing called a tyramine reaction. Certain foods that a patient might eat with these can cause like severe increases in blood pressure. And as well, they, just like all the other ones, they have potential for serotonin syndrome because they work on serotonin pathways in the brain. Now, the big thing to avoid with MAOIs are your indirectly acting sympathomimetics, like ephedrine, because there's going to be a very exaggerated blood pressure response and tachycardia. So these are considered contraindicated, and so their mechanism of this interaction is that they inhibit the norepinephrine metabolism because they inhibit that MAO enzyme, and so that is going to increase in greater norepinephrine stores in the neuron, in like the nerve endings. So when you give an indirectly acting sympathomimetic like ephedrine, it kind of releases all this norepinephrine all at once, and it can cause this spike in blood pressure. Versus your direct acting sympathomimetics like your phenylephrine, epinephrine, norepi, they don't have this effect because they're not like working to release all that norepinephrine all at once from the neuron. So theoretically you don't see that interaction. However, you should titrate it with caution because the receptors, the adrenergic receptors, can be a little more sensitive when a patient's on MAOIs. So even your direct acting sympathomimetics, you could see an increased blood pressure response to them. So the recommendation historically with your irreversible MAOIs has been to taper the patient off 2 to 3 weeks prior to surgery, but more recently it's been considered that this decision should like typically be made with a psychiatrist input because the risk of relapse may be too high. So it kind of has to be a risk versus benefit decision. And if the patient remains on MAOIs, it just needs to be, these interactions just need to be taken into account. Now, your reversible MAOIs, like your selegiline and rastagiline, you could just stop the day of surgery. Because they don't completely block that enzyme, it's okay to just stop them for a day, and you're not going to see all of these interactions. So the next class of medications is another older class, tricyclics, another one that has fallen out of favor, but you might see increased use recently. So again, they have a lot of the same uses, except the unique one with TCAs is chronic pain. You're going to see some of these used for headaches in much lower doses than is used for the psychiatric conditions. So some examples are imipramine, amitriptyline, clomipramine, nortriptyline, desipramine. Your common adverse effects are going to be very similar to MAOIs, and again, serotonin syndrome is is the serious effect to look out for. Now, perioperative concerns with these, so they can have the same discontinuation syndrome as the other antidepressants. However, it's a little bit more severe because it can cause cholinergic symptoms. Because this class of medications has anticholinergic activity, if you stop them abruptly, you might get some cholinergic. So patients can exhibit like signs of Parkinsonism, balance disturbances, abdominal pain, nausea, vomiting. So it's a little bit more severe of a discontinuation syndrome that you see with other antidepressants. Now, they may cause an increased anesthetic requirement because there's an increased availability of neurotransmitters in the CNS. And another concern is if you use anticholinergic agents that can have an additive anticholinergic effect. They do exhibit an exaggerated blood pressure response because they do have such a profound effect on the norepinephrine pathway, and there's an increased availability of norepinephrine in the brain. You can see this same exaggerated blood pressure response, especially with your indirectly acting vasopressors like ephedrine. It is less pronounced though, so it's not contraindicated like it is with MAOIs. It just has to be a careful titration if you do need to use it. But the recommendation is to continue these through the day of surgery because the discontinuation syndrome is so severe. And that can potentially be seen even with stopping one dose with these because a lot of them have a very short half-life. So typically you just continue and hopefully avoid these effects. Another thing, traditionally it's considered that ketamine should also be avoided with these because it also has a stimulatory effect on the sympathetic nervous system. So it's considered, it could be prudent to avoid ketamine with these. Okay. So then the next class that we're going to talk about is your typical antipsychotics. So your uses for these are going to be psychosis, schizophrenia, acute mania, agitation, and their mechanism of action is they antagonize your central dopamine signaling. So I'm sure you've seen some of these, so haloperidol, chlorpromazine, chlorproperazine. They're very useful, especially in the inpatient setting, and their common adverse effects. Extrapyramidal symptoms are something that you don't see with others that you see a lot with typical antipsychotics. So patients have this involuntary movement that can happen, restlessness. And your serious adverse effects with these that we really worry about is neuroleptic malignant syndrome, NMS, which again I'll talk about and try to differentiate from serotonin syndrome, and arrhythmia, which is again caused by QT prolongation potentially. And again, just like with everything else, it's an additive effect. You really only worry about it if the patient's on other agents that can prolong the QT. Then there's also the atypical antipsychotics, which are newer. They have less of your extrapyramidal symptoms, so they are prescribed more commonly, especially for long-term use. So a lot of patients on outpatient treatment, they won't be on typical antipsychotics, they'll be on these. So they have a lot of the same uses. They can be used as an adjunct treatment for treatment-resistant depression, especially like aripiprazole, Abilify. Mechanism, again, they antagonize the central dopamine signaling. However, they are a little more selective with the receptors that they hit, so that they don't cause as many of these unwanted side effects. Other common example is risperidone, olanzapine, ziprasidone, quetiapine, and then serious adverse effects are very similar, except you do worry about agranulocytosis with these, so you could see neutropenia, especially with clozapine, which is a typical antipsychotic that you'll see in a treatment-resistant case. It works on negative symptoms of psychosis that these other ones don't, so clozapine is becoming more and more popular. So something that we worry about is neutropenia with that. And they also carry the same risks with QT prolongation. So there are some concerns with these. There's been some reports with desflurane. There's been some reports of seizures if a patient's on these. Now again, these are just case reports. The incidence, there's no estimates of it. There's some caution with anticholinergics because some atypical antipsychotics have anticholinergic effects. And the recommendation, however, is to continue through the day of surgery because the big thing here is that the relapse potential is so high with some of these patients that really the risk of relapse outweighs any risk of interactions. And then you have your mood stabilizers. So we use these for bipolar disorder. These are going to modulate your glutamatergic and GABAergic neurotransmission. Their exact mechanism is unknown. So examples are lithium, valproic acid, and lamotrigine, carbamazepine. So common adverse effects that you might see are hand tremor, especially if the patient has too high lithium levels that are elevated. They're going to have excessive thirst, increased urination, and hydration is extremely important for these patients that are on lithium because they need to be able to clear that lithium to avoid lithium toxicity. So serious adverse effects are potentially Stevens-Johnson syndrome with lamotrigine. So if the patient develops a rash that can progress to this life-threatening syndrome, and NMS. So with these mood stabilizers, NSAIDs should be avoided because they can reduce the renal clearance of lithium. And the duration of depolarizing and non-depolarizing neuromuscular blockers may be prolonged. And they may have lower MAC anesthetic requirements. And the recommendation is to stop lithium 24 to 48 hours prior to the procedure. And then post-operatively, it's recommended to get a lithium level and then restart the patient back, titrate them back up. Now, I mentioned briefly, so neuroleptic malignant syndrome, I just want to get a little more in depth with that. It's something that you'll see very rarely, if at all, but it's something just to be aware of because it is very hard to differentiate diagnostically. So it is a life-threatening idiosyncratic reaction to medications with dopamine receptor antagonist properties, or it can be seen with rapid withdrawal of your dopaminergic medications that are used for Parkinson's. So your pathophysiology is the blockade of dopamine receptors, but the exact mechanism is still under investigation. So your signs and symptoms are going to be, so the patient can present with fever, altered mental status, muscle rigidity, and really it's like a neuromuscular hypoactivity. The patient's very lethargic, possibly catatonic in more severe cases, and they're going to have autonomic dysfunction, so labile blood pressure, tachycardia, tachypnea, diaphoresis, flushing. So risk factors are if the patient's on any typical or atypical antipsychotics. It has been reported with all of them, although the higher potency typical antipsychotics are thought to have a greater risk of this. Also your long-acting depot formulations, like if the patient's on like a once a month or once every 3 months long-acting antipsychotic, you have like aripiprazole, extended action, there's a couple other ones, then they're at an increased risk because it stays in their system for a long time. Also, it has been seen with things like metoclopramide and promethazine, which are used as antiemetics, really not antipsychotics, but they do have an activity on the dopaminergic system. But it's more rare with those. And like I said, with those Parkinsonian medications like levodopa, carbidopa, bromocriptine, ropinirole, if the patient has missed their doses or hasn't taken them there could be this withdrawal. It could be a response to the withdrawal of that dopamine stimulation. The incidence is very low. And it's decreased now that there's more awareness of it, and a lot less of the typical antipsychotics are used, and practice has gone toward more atypical antipsychotics. So that it can be anywhere from 0.02 to 3%, and the 3% is really more from inpatient psychiatric settings, where these patients are on much higher doses and multiple antipsychotics. 0.02 might be more representative of your general population that's on these medications in an outpatient setting. So the biggest piece of management for this is really just discontinue that offending antipsychotic right away. Aggressive hydration, especially if they have elevated CK enzyme. And then benzodiazepines are going to be your first line for a mild case, especially if a patient has primarily catatonic symptoms. The benzos can help get them out of that. But it's also useful if for some reason they present with agitation. Now, in actual severe case, you're going to want to use bromocriptine, which is a dopamine agonist. And so the dose gets titrated to effect. And it should be continued for 10 days for NMS related to oral antipsychotics. But if it's those long-acting depot injections, it's going to be 2 to 3 weeks to try to counteract that. Amantadine is also used as a substitute. Also, dantrolene is used for severe cases. You might recognize that as also it's used for treatment of malignant hyperthermia. These are similar conditions in terms of their effects and presentation, and dantrolene does also work. So it's typically discontinued once symptoms begin to resolve because of concerns of hepatotoxicity with long-term use. And the last line for a patient that's not breaking out of their catatonic state, if nothing else works, then you can use electroconvulsive therapy, or ECT. And then serotonin syndrome is, again, it has somewhat of a similar presentation to NMS. It is also potentially life-threatening syndrome, and that's caused by the overactivation of both your peripheral and central postsynaptic serotonin receptors. And it's caused by these additive effects of multiple serotonergic medications, increasing your serotonin levels. And your signs and symptoms are going to be mild hypertension, tachycardia, mydriasis, in mild cases, diaphoresis, shivering, myoclonus. In moderate, usually you'll get all of that plus temperature above 40 Celsius, so they're going to be febrile. They might start having hyperactive bowel sounds, and then start to have this horizontal ocular clonus, and mild agitation, pressured speech. And then a severe case, you're going to have really, they're going to be very febrile, above 41 Celsius. They're going to have these signs of autonomic dysfunction, your labile vitals, delirium, muscle rigidity, and it can have various end organ complications at that point. So risk factors, like I said, co-administration of multiple serotonergic medications, and patients with end-stage renal disease, they have an increased incidence of this happening. Thought to be due because there is some renal clearance involved with some of these medications. So if you have patients with ESRD, have an increased potential for it. So your management in a mild case is really supportive care and discontinuing the offending agent. And in a moderate case, you could consider using, there is a 5-HT receptor antagonist to try to counteract all this overstimulation. It's called cyproheptadine. And at this point, the patient would need to be admitted to the floor. And then in severe cases, you would start to correct all their like hypotension and their vitals, give them oxygen, and they may have to be admitted to the ICU at that point. So the differential with these, and that's one of the biggest challenges, is when you have a patient that presents, they're stiff, they have a high temperature, all of these can cause that. So one of the things is the biggest piece in the differential here is the medication history, right? So what's this patient been taking at home? Have they been on a bunch of serotonergic medications? Have they been taking antipsychotics? And the other piece is the onset. So the time of onset of serotonin syndrome, it usually develops within a day or two. So another differential piece with serotonin syndrome is that these patients typically have myoclonus as one of their presenting symptoms, and they're going to have this neuromuscular hyperactivity. Versus NMS, it's a hypoactivity. So these patients are very stiff and lethargic. the other, neuroleptic malignant syndrome also develops over the course of usually a few weeks. So these patients usually, they wouldn't just come in and suddenly have all of this. This would be a gradual increase in severity. Now with malignant hyperthermia, that one is really, it develops in a few minutes to hours after administration of succinylcholine or anesthetic. So that one you can usually tell based on what you just gave the patient. And then anticholinergic toxicity, that one's differentiated because the patient would have mydriasis, decreased secretions, but their muscular tone and reflexes would be normal. So that's how you could tell. Also, again, medication history with that one. Was the patient on any anticholinergics at home chronically? So that is that. Any questions?
It's a lot of information.
I know, I try to pack a lot in a short amount of time. So
yeah, that is a lot of information
Yeah.
to digest.
Yeah.
Can you summarize, because you presented so many different classes, what should be red flags to us when we're seeing patients in Kriya and there's like all these medicines? I'm not
Right.
gonna know which ones are MAOIs, which ones are tricyclics, like,
Yeah.
but are there some certain drugs that should be like red flag, okay, this should be held before surgery?
Right.
The only one
Really?
I know is phenolzine. That's the only one I know.
Yeah, and that's a lot
I
of
know
these.
for the MAOIs, you can't have Demerol, that is a terrible drug interaction, but I don't
Right.
know, like, what are the other red flags?
Really, yeah, these are the ones you'll see most often. Any of these are red flags. Again, especially those the non-selective ones, so phenelzine, tranylcypromine, isocarboxazid. They're seen pretty rarely, especially those last two. But those are the big ones.
Should we cancel surgery if they're on those and they haven't been discontinued?
No. So I don't think you should, because there are some cases where you can't
Stop them.
you can't stop them.
Yeah.
So really, it's just a matter of not using ephedrine,
Demerol.
Demerol, just not using some of these medications like ketamine, pancuronium can have actually some potential for sympathomimetic stimulation. So just avoiding those few, but your other pressors like norepinephrine, epi, phenylephrine are fine. You could just uptitrate them gradually, and the other neuromuscular blockers are fine. So there are options. You just want to avoid a few. There's just a few things. So no, yeah, it's not gonna. I don't think it should be a reason for canceling it. Yeah.
Over the years, we've had a few cases in recovery where we don't know. Is it reasonable to call a pharmacist and have them come and help us evaluate this whole thing by looking at the medications?
I think so. I think that would be
Should
reasonable.
we call you, like a psychiatric pharmacist, or
so-
usual OR pharmacist, or who do we?
Probably I would say the OR pharmacists because they could respond the quickest. Yeah, I think they're technically respond for the OR area, so
Good
you can
luck.
call them.
You call that number, you leave a message.
No, I know because
And
they
then
are.
they'll call you back.
I know it's bad. Like
Look.
we honestly need it's a staff issue. We need more people in that area because they're covering the ER and OR. You can imagine the craziness. Yeah.
Why are these being used more? You mentioned that they're being more frequently used.
Yeah, I think it's because so some patients there's a certain percentage of patients that don't have any effect to your SSRIs and SNRIs, and so the psychiatrist may try one of these if nothing else is working. And
Is that because they develop a tolerance over time to these things? Because I feel that people are using psych drugs at a younger and younger age. And you didn't mention like anything about Zoloft. I mean, I'm thinking that's
sertraline, yeah,
so I don't know which class I would.
that's an
recommend.
SSRI, yeah.
A lot of patients are on that.
Right. Sertraline, yeah. That's one of the SSRIs, that's one of the safer ones that you're not going to really see a whole lot of interactions with. But yeah, that's really the reason I think is that they're running out of therapeutic options. And so they're going toward these more risky
So
medications.
basically, when you're saying is, if you see any of our patients are on antipsychotic drugs and you don't really know what class, when you do a sympathomimetic, just charge it really slowly and do a direct versus indirect.
Yeah.
Really short.
Right. I think that would be the safest.
And then
approach.
you look for increasing temperature versus
Right, and then to look for one of those syndromes, for example, like MS.
But it's
yeah.
only 0.2% to 3.
It's you're very
So it's
unlikely.
very small.
You're honestly very unlikely to see it. They're
It's
very
like
rare.
hyperkalemia.
Well, the other thing the case that I got into was a 15-year-old girl who's on a bunch of psych meds now. Is she acting out? I mean, you couldn't tell us if the medication, is she acting out?
Yeah.
What's going on? Crazy mom. You know, there's so many different factors that
Yeah.
go into this. It's hard to call it.
Right. No, absolutely. Yeah. And the other piece is that some of these patients on antipsychotics, they might be on chronic anticholinergics to counteract like the extrapyramidal symptoms. So try to differentiate: is it anticholinergic toxicity or is it MS? Yeah. It's
Meditation, that's the key. Meditate. You won't need to be on all these medications.
right. Yeah.
Thank you.
Sure.
Thank you. That was great. That's a lot of